Okay, picture this scenario. You're in the clinic.
Right.
It's a busy Tuesday afternoon, the kind where you're already running 20 minutes behind schedule.
Oh, I know them well. The kind that feels like you're just trying to keep your head above water.
Exactly. And a patient walks in, and frankly, they look exhausted. They sit down and start listing their symptoms, and at first, it sounds like they're reading randomly from, I don't know, 3 different medical textbooks.
The classic review of systems disaster, the kind that makes you want to call for a consult immediately because nothing connects.
Nothing connects. They look you in the eye and say, "Doctor, my face, it just goes bright red out of nowhere. It feels like I'm burning up, totally unprovoked."
Okay, so you're thinking maybe rosacea, maybe an allergy, something dermatological.
Right. Then they say, "And I'm in the bathroom 10 times a day with this just uncontrollable diarrhea."
So now you've pivoted. Now it's a GI problem. Maybe it's IDD, maybe some kind of infection.
Exactly.
Yeah.
And then just when you think you have a handle on it, you think it's a gut issue or a skin issue, you put your stethoscope on their chest. And you hear this distinct sort of mechanical murmur on the right side of the heart.
Right. So you have a dermatologist's problem, a gastroenterologist's problem, and now a cardiologist's problem all rolled into one patient. That is a diagnostic nightmare.
It's a complete nightmare. And to cap it all off, you do a scan and you find a mass. But the mass isn't in the heart and it isn't in the skin. It's in the small intestine.
Which, on the surface, seems completely, utterly disconnected from heart failure or facial flushing.
It feels random. It feels like just the worst luck, hitting 3 different systems all at once. But here is the hook. This is the thing that turns this from just a list of symptoms into a real medical thriller.
Okay.
This entire storm, the flushing, the heart damage, the gut issues, it all depends on one specific organ. And it's not the organ with the tumor.
It's the liver.
It's the liver. The central mystery we are going to crack today is, why is the liver the gatekeeper for this disease? Why does the liver get to decide if you just have a silent lump in your belly or if you have a life-altering systemic syndrome?
It is a fascinating question of, well, plumbing, biochemistry, and you could even say evolution.
Today, we are doing a deep dive into neuroendocrine tumors, or NETs. And I have to say, looking at the research you've pulled together, this is a topic that sits right at the intersection of, well, everything.
It really does. It forces you to use every part of your medical brain. You've got anatomy, physiology, endocrinology, oncology. If you really understand NETs, you understand how the body integrates its systems.
Right.
It's not just about a lump growing. It's about a message being sent, a chemical message.
So let's start at the very beginning. The name itself is a bit of a mouthful. Neuroendocrine. It almost sounds like a contradiction in terms.
Yeah, it does, doesn't it? It implies 2 different systems that we usually keep very separate in our minds. And that's because these tumors arise from cells that they really have a split personality. They're hybrid cells.
A hybrid of what, exactly?
Well, think of them as the interface, the bridge between your nervous system and your hormonal or endocrine system. On one side, the neuro side, they have traits just like nerve cells.
Okay.
Under an electron microscope, you can see these things called dense core granules. They look a bit like what you'd find in a neuron. They are fundamentally wired to receive signals.
But they don't fire electrical signals like a typical nerve. They don't, shock you.
No, and that's the endocrine side of the coin. Instead of firing electricity along a wire, they manufacture chemicals. They're little factories.
Factories.
Yeah, they take precursors, simple amino acids just floating around in your blood, and they turn them into these complex, powerful hormones, which they then store in little packets called vesicles, just waiting to be released into the blood.
So they're like nerve cells that decided to go into the manufacturing business instead of communications.
That is a perfect way to put it. And because they are factories, they can produce some of the most potent chemicals in the human body. We're talking about things like insulin, serotonin, gastrin. These aren't just waste products. These are the control signals for your entire metabolism and your digestive system.
Which brings us to how we actually spot them in the lab. If a pathologist is looking at a slide, they can't see the personality of the cell, right? They need proof. What are the molecular tags or the ID cards that these cells carry?
Right, so we rely on something called immunohistochemistry, which is basically just using chemical stains that turn a specific color when they hit a specific target protein. For NETs, there are 3 big ones you absolutely need to know. The first 2 prove the cell's identity. They tell us, yes, this is definitely a neuroendocrine cell.
Okay, so what's the first one?
The first one is chromogranin A. This is a protein that's found inside those secretory granules we just talked about, the little packets of hormones.
Oh.
So if a cell lights up with the chromogranin A stain, it's a very strong sign it's part of this family. It's probably the most specific general marker we have. It's essentially the cell raising its hand and saying, I have packets of hormones ready to go.
Got it. And the second identity marker?
The second one is synaptophysin. And this one is found in the synaptic vesicles, again, pointing directly back to that neural heritage we were talking about. So if you have a tumor and it stains positive for both chromogranin and synaptophysin, you've made your diagnosis of a NET. You know the family it belongs to.
But making the diagnosis, that's just step one, because not all NETs are created equal, right? I mean, some are lazy and slow and others are incredibly aggressive. How do we tell the difference?
That is where the third marker comes in. And, for the oncologist and especially for the patient, this is arguably the most important number on that whole pathology page. It's the Ki-67 index.
Ki-67. I always see this on pathology reports. This is basically a speedometer for the tumor, right?
It is exactly a speedometer. It measures the percentage of cells that are actively dividing, specifically, the cells that are not in the resting phase of their life cycle. It's a direct measure of cellular proliferation. It answers the one big question: how fast is this thing moving?
So a low number is what you want to see.
Generally, yes. If the Ki-67 is less than 3%, we call that a grade 1 NET. These are what we call well-differentiated. They look a lot like normal cells, just more of them. They are slow-growing, indolent. A patient might live with one of these for years and years without it changing much at all.
It's like the tumor is driving through a school zone.
A school zone, exactly. But what if the number is high?
Right.
If it's above 20%, or certainly if it's above 50%, we are in a completely different world. We stop calling them neuroendocrine tumors and start calling them neuroendocrine carcinomas, or NECs.
Carcinomas. That's a big shift in terminology.
It's a huge shift. These are poorly differentiated. They look wild and disorganized under the microscope. They are aggressive, they spread fast, and they need heavy-duty chemotherapy, like yesterday.
So Ki-67 basically tells you if you're driving in a school zone or if you're on the Autobahn with no brakes.
Precisely. And that one number dictates your entire treatment plan. But, and here is the nuance that trips everyone up, students and doctors alike, just because a tumor is a neuroendocrine tumor doesn't automatically mean the patient is having those crazy symptoms we talked about in the intro.
Right. And this is the huge distinction between functioning and non-functioning tumors.
Correct. And this is the biggest exam trap and, frankly, a clinical trap, too. You see neuroendocrine tumor on a chart, and your brain immediately jumps to flushing or low blood sugar. But the majority of these tumors, especially the ones found in the pancreas, are actually non-functioning.
So they're silent? Hormonally silent?
Hormonally silent. They might be secreting a little bit of something, or maybe they're secreting a hormone that doesn't actually do anything systemically in that quantity. So these patients don't come in complaining of hot flashes or dizziness. They come in because their skin is yellow.
Jaundice.
Yes, because the tumor has grown so big, it's physically crushing the bile duct. Or they have terrible back pain because it's pressing on nerves. We call this mass effect. The problem isn't the hormone, it's the physical size of the tumor.
So a non-functioning tumor is a structural problem. It's like a rock in the road.
A rock in the road.
But a functioning tumor is a chemical problem. It's a factory spewing out pollution.
Exactly. And for the purpose of this deep dive, we're going to focus on the functioning ones, because that is where the physiology gets really, really interesting. We want to move beyond just memorizing a list of symptoms. The goal here is to decode the logic of the hormones.
I love that phrase, decoding the pattern. So let's start with the first big category. We're going to the gut. This is part one, the carcinoid enigma.
GI neuroendocrine tumors, or as they were historically called, carcinoid tumors.
Carcinoid. That's an old term, isn't it? It sounds a lot like cancer-like.
It does. It was actually coined in the early 1900s by a German pathologist. He saw these tumors and thought, well, they look sort of like carcinoma, but they grow much, much slower. So carcinoid, cancer-like. We try to use the more precise term neuroendocrine tumor now, but carcinoid syndrome is still the proper medical term for the symptoms.
Okay, that makes sense. So with real estate, it's all about location, location, location. Where are we usually finding these gut tumors?
They can pop up anywhere from the stomach all the way down to the rectum, but the hot spot, the classic location that you have to know, is the small intestine, and specifically the ileum. That's the very last part of the small bowel, right before it hits the colon.
Okay, so we're in the ileum. We have a well-differentiated tumor, and it is pumping out a chemical. What is the weapon of choice for these tumors?
Serotonin.
Serotonin. Now, usually when people hear serotonin, they think of antidepressants. They think of the brain, the happy chemical.
That's the PR campaign for serotonin, right? But biologically, something like 90% of your body's total serotonin is actually made and stored in the gut. Its day job is regulating intestinal movement. It tells the gut muscles to contract and move food along.
But in a tumor, that regulation is just gone.
Completely gone. The tumor is acting like a runaway factory with no off switch. It is dumping massive, uncontrolled amounts of serotonin into the bloodstream.
Okay, so here is the puzzle.
Okay.
You have a tumor in the ileum. It is dumping serotonin into the blood vessels that surround the gut. Why doesn't the patient immediately turn bright red and start having diarrhea? How can you have a huge tumor there and feel totally fine?
This brings us to what I call the liver filter rule. This is probably the single most important concept to grasp for all GI nets. You have to visualize the plumbing of the human body.
Walk us through that plumbing.
Okay, so all the blood that drains from your intestines, carrying all the nutrients from your lunch, any toxins, and in this case, all that serotonin from the tumor, it does not go straight to your heart and around your body.
It takes a detour.
It takes a mandatory detour. It all gets funneled into one massive blood vessel called the portal vein.
And the portal vein is the superhighway to the liver.
Correct. The liver is the body's main detoxification center. It's the bouncer at the club door. Its job is to inspect everything coming from the gut before letting it into the main systemic circulation. And the liver has these enzymes, specifically an enzyme called monoamine oxidase, that are incredibly efficient at breaking down serotonin.
So the tumor dumps the serotonin, it flows directly to the liver, and the liver just destroys it.
It metabolizes it into an inactive waste product. So by the time that blood leaves the liver through the hepatic veins and goes to the heart and the rest of the body, the serotonin is gone. It's been scrubbed clean.
So the patient has no symptoms because the liver is just doing its job perfectly. It's protecting the rest of the body.
Exactly. This is why you can have a primary tumor for years and years and never even know it's there. But what happens when the bouncer gets overwhelmed? Or even worse, what happens when the tumor bypasses the bouncer completely?
This is the turning point. This is when carcinoid syndrome actually appears.
Carcinoid syndrome, the flushing, the diarrhea, all of it, it almost exclusively occurs when you have liver metastases.
So the tumor has to physically spread to the liver itself.
Yes. But think about the anatomy for a second. If a tumor nodule is growing inside the liver tissue, it isn't draining into the portal vein anymore. It's shedding its serotonin directly into the hepatic veins.
And the hepatic veins drain out of the liver. They're downstream.
Bingo. They drain directly into the inferior vena cava, which goes straight to the heart. They are downstream of the filter. The serotonin is being dumped straight onto the main highway, completely bypassing all the detoxification enzymes.
The bouncer's been flanked. The enemy is already inside the club.
That is a perfect analogy. Once you have liver mets, the shield is down. The systemic circulation is flooded with serotonin.
And that's when the patient walks into your office looking like they just ran a marathon while having food poisoning. Let's break down the classic triad of symptoms. First, the flushing.
Yeah, and this isn't just a little pink in the cheeks like you're embarrassed. This is a profound, deep red, or even purplish cutaneous flush. Usually the face, the neck, the upper chest.
What triggers it?
It can be triggered by things that dilate blood vessels, a glass of red wine, stress, even spicy food.
Yeah.
It's often what we call dry flushing, so not a lot of sweating, but the patient says it feels incredibly hot.
It's just this massive vascular instability.
Right. Serotonin and other vasoactive substances are forcing all these blood vessels to dilate inappropriately.
Okay, second symptom, the gut.
Secretory diarrhea. And this is just miserable for patients. Serotonin's day job is to make the gut move. When you have way too much of it, you get hypermotility. The gut is contracting so fast it can't absorb water.
So the volume must be huge.
Huge. Patients can have 10, 20 watery bowel movements a day. It's completely debilitating.
And the third classic symptom involves the lungs.
Bronchospasm. The smooth muscle in the airways constricts. The patient starts wheezing, feels short of breath. It can look a lot like a new onset asthma attack, and in fact, many patients are misdiagnosed with asthma for years before anyone finds the underlying tumor.
So flushing, diarrhea, wheezing, that's the classic carcinoid syndrome. But we haven't even talked about the most dangerous part of this yet, the heart.
The heart defect puzzle. This is a very high-yield concept for anyone interested in pathology mechanism.
We mentioned in the intro that it specifically affects the right side of the heart. Why is that? Why not the whole heart?
It's another plumbing issue. You just have to follow the flow of the serotonin. It leaves the liver mets, goes into the vena cava, and the very first chamber of the heart it enters is the right atrium. Then it goes through the tricuspid valve into the right ventricle.
So the tricuspid valve and the pulmonary valve, they're getting the first, most concentrated blast of this toxic serotonin-rich blood.
Exactly. And we now know that high sustained levels of serotonin are fibrogenic. They are toxic to heart valves. It stimulates fibroblasts, the cells that make scar tissue, to just go crazy. It causes these thick, white, fibrous plaques to form on the valve leaflets.
Scars them down and makes them stiff.
It essentially freezes them in place. The valves become stiff and retracted. They can't close properly, so you get this massive tricuspid regurgitation. The blood leaks backward every time the heart beats.
Which leads to right-sided heart failure.
Classic right-sided heart failure, swollen legs, a big congested liver, fluid retention in the abdomen.
Okay, so the right side of the heart is completely wrecked, but then the blood leaves the right ventricle and goes to the lungs. And this is where the magic happens.
This is the aha moment. The lungs are not just gas exchange bags. They are incredibly metabolically active organs, and just like the liver, they also possess that enzyme, monoamine oxidase.
The very same enzymes the liver has.
The very same one. So as all that blood passes through the tiny pulmonary capillaries, the lungs act as a second filter. They scrub the remaining serotonin out of the blood.
So by the time the blood leaves the lungs and comes around to enter the left atrium and the left ventricle,
The serotonin is gone. The left-sided valves, the mitral and aortic valves, are completely spared. They see clean, filtered blood.
that is just incredible. The lungs actively protect the left side of the heart.
It's a beautiful piece of physiology. It's a localized toxicity based purely on the dynamics of blood flow. It also means if you see a patient with carcinoid symptoms and they do have left-sided heart disease, you have to look for something weird,
Like what?
like a hole in the heart, a pattern-forming oval, or an atrial septal defect that allowed the blood to shunt from the right side to the left, skipping the lungs. But 95% of the time, it's a purely right-sided phenomenon.
That makes the clinical picture so clear. If I hear a tricuspid murmur and see a flushed face, I know exactly what's happening biochemically. Now, how do we confirm this? You can't just draw a blood sample for serotonin, can you?
You can, but it's really messy. Serotonin is released in pulses. It fluctuates wildly throughout the day depending on what you eat or if you're stressed. It's also stored in platelets, so if the blood clots in the tube, the platelets pop and release all their serotonin, giving you a falsely high reading. We need a more stable marker.
You need to look in the trash can, not at the factory floor.
Exactly. We measure the breakdown product. When the liver or the lungs break down all that serotonin, they turn it into a stable waste product called 5-HIAA.
5-hydroxyindoleacetic acid.
Try saying that 3 times fast. We measure 5-HIAA in a 24-hour urine collection. This is great because it integrates the total production over a whole day, smoothing out all those peaks and valleys. If that number is high, you have your diagnosis.
But there's a famous catch with the urine test, right? I remember reading something about bananas.
Yes. The infamous banana false positive. Certain foods are naturally very high in serotonin, or its precursor, tryptophan. Things like bananas, walnuts, pineapples, avocados, pecans.
That sounds like a delicious trail mix.
It is. But if you eat a big bowl of guacamole and a banana split the day before your 24-hour urine test, you might test false positive for a tumor. The lab sees all the 5-HIAA and assumes it's from a cancer, but really, you just had a snack.
That is a very specific dietary warning. Please refrain from avocados until we've ruled out the cancer.
It's true. Patients have to go on a specific bland diet for 24 to 48 hours before the test. It's a really critical detail to ensure accuracy.
Okay, that covers the gut and the carcinoid enigma. It's all about the liver filter and the plumbing of the heart and lungs. Now let's move upstream. We are leaving the bowel and heading into the pancreas. Part 2. The pancreatic parade.
PNETs. Pancreatic neuroendocrine tumors.
How is this different from what we just discussed in the gut?
Well, the complexity really ramps up. In the gut, it's mostly just serotonin doing the talking. But the pancreas is an endocrine powerhouse. It has all these different islet cells, alpha cells making glucagon, beta cells making insulin, delta cells making somatostatin, and each one can form its own unique tumor.
So depending on which specific cell type turns into a tumor, you get a completely different disease.
Exactly. It's not just a binary question of is it functioning, it's what is it making. And each of these syndromes is incredibly distinct. They are like different characters in a play, each with their own story.
So let's start with the most common functioning PNET, the insulinoma.
The The name tells you the whole story. It's a tumor of the pancreatic beta cells, and it does one thing. It pumps out insulin.
And we all know what insulin does. It drives sugar from the blood into the cells. It lowers your blood sugar.
So these patients present with hypoglycemia, but this isn't the I skip lunch and I feel a bit hangry kind of hypoglycemia. This is profound, dangerous hypoglycemia, blood sugar dropping into the 40s or 30s.
What does that actually look like for the patient? What do they feel?
It's terrifying. It looks like a massive sympathetic overdrive because the body panics. You get sweating, tremors, palpitations, intense anxiety, and then you get neuroglycopenia. The brain is literally starving for fuel. That leads to confusion, bizarre behavioral changes, slurred speech.
So they might seem drunk or like they're having a psychiatric episode.
Absolutely. Patients have been misdiagnosed with psychiatric disorders or even arrested for drunk driving because they act so strangely when their sugar is that low.
I've also heard that patients with insulinomas often gain weight. That seems a bit counterintuitive.
Yes, it's a learned survival mechanism. They figure out either consciously or unconsciously that eating makes that horrible feeling go away, so they are constantly snacking on carbs and sugary drinks to keep their blood sugar from crashing. A patient with unexplained weight gain and fainting spells. You have to think about an insulinoma.
So how do we prove it? Is there a formal checklist for diagnosis?
There is. It's called the Whipple triad. This is the gold standard diagnostic criteria described back in the 1930s. You need all three things to be present to diagnose an insulinoma.
Okay, what's criteria number 1?
First, you have to document the symptoms of hypoglycemia. The sweating, the confusion, the palpitations. You have to witness the event.
Criteria number 2.
You need to have a documented low blood glucose level at the exact time of those symptoms. You have to catch it in the act. You have to see the number is low while they are feeling bad.
And what's the third part of the triad?
Immediate and complete relief of symptoms right after you give them glucose. If you give them a glass of orange juice or an IV of dextrose and they wake up and feel totally normal within minutes, that completes the triad.
It proves cause and effect. The low sugar caused the symptoms. Now, is this cancer? Is it malignant?
So here is some genuinely good news in this field. The vast majority, around 90% of insulinomas, are benign. They are typically solitary, small, benign tumors. If a surgeon can find it and cut it out, the patient is completely cured. It's a beautiful surgical fix.
That is fantastic news. But I have a feeling the next one on our list isn't so friendly. Let's talk about the gastrinoma.
Yeah, this is the other end of the spectrum. Gastrinomas are frequently malignant. They are cancerous, and they like to spread.
And they produce the hormone gastrin. What does gastrin normally do?
Gastrin is the drill sergeant for the stomach. It marches up to the parietal cells in the stomach lining and commands them to secrete hydrochloric acid.
So if you have a tumor that's just pumping out gastrin all day, the stomach is just churning out acid 247 with no off switch.
Exactly. It creates an unbelievable acid bath in the upper GI tract. This leads to a condition called Zollinger-Ellison syndrome.
Named after the doctors who first described it.
Yes. In the 1950s, two surgeons, Robert Zollinger and Edwin Ellison, described two patients who had these severe, uncontrollable peptic ulcers and also happened to have tumors in their pancreas. They were the first to put 2 and 2 together.
So the main symptom here is ulcers.
But not just your garden variety ulcer from stress or taking too much ibuprofen. These are ulcers from hell. They are often multiple, they are recurrent, they come back right after you stop the acid medication, and most tellingly, they are in weird places.
Weird places? What do you mean?
Well, usually peptic ulcers are in the stomach or the very first part of the duodenum. In Zollinger-Ellison, because there's so much acid, you might find ulcers way down in the distal duodenum or even in the jejunum. Acid just should not be reaching that far down the intestine.
So if I see an ulcer in the jejunum on an endoscopy report, that is a massive red flag.
A huge red flag. It's almost diagnostic. And there's another symptom that often confuses people, diarrhea.
Wait, why diarrhea? I thought this was a stomach acid issue.
It's because of the acid. Your pancreatic enzymes, the ones you need to digest fat, they need a neutral or slightly alkaline pH to work properly. If the stomach dumps a ton of acid into the intestine, it overwhelms the bicarbonate buffer and inactivates the enzymes.
So you can't digest your food.
You can't digest fat, so you get steatorrhea fatty, floating, foul-smelling diarrhea, and malabsorption.
So refractory ulcers plus diarrhea should make you think gastrinoma.
Correct. And remember, unlike the insulinoma, this is often malignant and can metastasize early, often to the liver.
Okay, moving down the pancreatic parade. This next one has a very dramatic nickname. You called it pancreatic cholera.
The VIPoma.
VIP stands for vasoactive intestinal peptide.
Right. VIP is normally a regulator. Its job is to tell the intestinal lining to secrete water and electrolytes. It relaxes the smooth muscle of the gut and kind of opens the floodgates to help things move along smoothly.
And when you have a tumor making it, those floodgates are just stuck wide open.
All the time. We use the mnemonic WDHA to describe the resulting syndrome.
Let's break down WDHA for everyone.
Okay, so the WD stands for watery diarrhea, and we need to emphasize the sheer volume here. This isn't just a loose stool. Patients can lose liters and liters of fluid a day. We're talking 5 to 10 liters sometimes. The stool is often described as looking like tea. It's a profound secretory diarrhea.
That explains the cholera nickname. It mimics the lethal dehydration you see in cholera.
It does, exactly. Now, because you are losing so much fluid from the gut, you are also losing a massive amount of electrolytes. Specifically, potassium. That gives us the H hypoglycemia, or low potassium.
Which is really dangerous. It can cause severe muscle weakness and life-threatening heart arrhythmias.
Very dangerous stuff. And finally, the A stands for achlorhydria, which means a lack of stomach acid.
Wait, why no acid? That seems odd.
Because VIP is a powerful inhibitor of gastrin secretion. It actively shuts down acid production in the stomach, so it's the exact mirror image of the gastrinoma. Gastrinoma is high acid, VIPoma is no acid.
That's a great way to remember it. WDHA, watery diarrhea, hypokalemia, achlorhydria.
You got it, that's the one.
Next up, the glucagonoma.
Right, so glucagon is the hormone that does the opposite of insulin. It raises blood sugar. So predictably, these patients often present with mild diabetes, but honestly, lots of people have new onset diabetes. That's not how you spot this tumor.
So how do you spot it? What's the giveaway?
You have to look at their skin. These patients develop a very specific, very distinctive rash called necrolytic migratory erythema.
Wow, that sounds like a heavy metal band name. Necrolytic migratory erythema. Can you break that down for us?
Sure. Necrolytic means tissue death. Migratory means it moves around, and erythema just means redness. So it's a painful, blistering red rash that tends to heal in the center and then spread outward at the edges, and it moves around the body, usually showing up in the groin, on the buttocks, and down the legs.
Why does this happen? What's the mechanism?
We think it's due to the severe catabolic state the tumor induces. Glucagon is a breakdown hormone. It breaks down proteins and fats to make sugar. The patients become profoundly amino acid deficient. Their skin literally starts breaking down because the tumor is consuming all the body's building blocks.
That is horrifying. So if you see a patient with new onset diabetes, significant weight loss, and this weird, moving, painful rash,
you have to screen them for a glucagonoma. It is the textbook presentation.
Okay, last one in the pancreatic parade. The really rare one, the somatostatinoma.
The rare one? Indeed. Somatostatin is known as the great inhibitor. Its physiological role is basically to say stop to everything else in the neighborhood. It stops insulin release, it stops glucagon release, it stops gastrin, it stops gallbladder contraction.
It's the wet blanket of hormones, the ultimate party pooper.
That's a great description, exactly. So if you have a tumor that's just pumping this stuff out, everything shuts down. You get a classic triad of symptoms based on what is being turned off.
Okay, let's try to guess them. If it inhibits insulin release.
You get mild diabetes.
If it inhibits gallbladder contraction.
The bile just sits there, it gets sludgy, and it turns into stones. You get gallstones.
And if it inhibits the release of pancreatic digestive enzymes.
You can't digest fat, so you get steatorrhea, the fatty stools again.
Diabetes, gallstones, and steatorrhea. It's this very distinct clinical picture of system-wide shutdown.
It is. But because these symptoms are all somewhat vague on their own, lots of people have gallstones and diabetes, these tumors are often found very late when they're already quite large.
That covers the pancreas, a really fascinating group of diseases. So we've done the gut, we've done the pancreas. But we hinted earlier that sometimes these tumors aren't solo actors. Sometimes they are part of a larger genetic syndicate.
Part 3, the genetic connection. Yes, we absolutely have to talk about the MEN syndromes.
Which stands for multiple endocrine neoplasia.
Right. This is critical. If you have a patient with a neuroendocrine tumor, especially if they're young, you have to ask the question, is this just a random bit of bad luck, or is this part of an inherited genetic syndrome?
And specifically, For the tumors we've been talking about, we are looking for MEN1, correct?
Yes. MEN1 is the syndrome that is most tightly linked to what we've discussed today. There is a classic mnemonic to help you remember the organs involved in MEN1, the 3Ps.
Okay, let's list the 3Ps. What's the first one?
The first P is parathyroid. The parathyroid glands control calcium levels in the blood. In MEN1, patients get hyperplasia or overgrowth of all 4 parathyroid glands, leading to hyperparathyroidism and hypercalcemia.
High calcium. That's the stones, bones, abdominal groans, and psychic moans.
Exactly. The second P is pancreas. Specifically, the pancreatic nets we just spent all that time on, gastrinomas and insulinomas, are the most common P nets seen in MEN1.
And the third P?
The third P is the pituitary gland. Patients usually develop a benign adenoma in the anterior pituitary gland in the brain. It might secrete prolactin, causing hormonal issues, or just grow and cause headaches.
Parathyroid, pancreas, pituitary.
Now, let's apply this in a clinical setting. Remember our gastrinoma patient, the one with the terrible recurrent ulcers?
Yeah, of course.
Imagine that patient comes in and you treat their ulcers with a high-dose medication, but then you happen to look at their routine blood work and you notice that their calcium level is high. A little bell should go off. Lights should be flashing in your brain.
Because high calcium means a parathyroid problem. The stubborn ulcers mean a pancreas problem. You have 2 of the 3 Ps.
Bingo. You've connected the dots. You've just diagnosed MEN1 syndrome, and this changes everything. Now you need to screen their pituitary with an MRI. You need to counsel them about genetic testing. You need to screen their children and their siblings. You have moved from just treating a symptom to treating an entire genetic family line.
That is incredibly powerful medicine. Just to be clear, so we don't get confused, what is MEN2? How is it different?
MEN2 is a totally different beast caused by a different gene mutation. It also involves endocrine tumors, but a different set. The classic MEN2 association is medullary thyroid carcinoma and pheochromocytoma, which is a tumor of the adrenal glands. It does not typically involve these pancreatic nets or the parathyroid hyperplasia.
So if you hear thyroid and adrenal, your brain should go to MEN2. If you hear pancreas and parathyroid, you should be thinking MEN1.
Exactly. Just stick to the P's for MEN1.
Okay, this is great. We've identified all the suspects. We know the plumbing. We know the gangs they run with. Now let's talk about part 4, finding and fixing. How has modern technology changed the game in hunting these things down?
Well, imaging has gone through a complete revolution in the last couple of decades. In the old days, what we used was something called an Octreotide scan. And it was okay, but it was grainy, low resolution. It was like watching a movie on a fuzzy black and white TV from the 1980s.
How did it work conceptually?
We knew early on that most of these well-differentiated tumor cells have a huge number of receptors on their surface, specifically somatostatin receptors. So the scan involved injecting a radioactive version of somatostatin, or its analog octreotide. It would float through the blood, stick to the receptors on the tumor, and then emit a gamma signal that a camera could pick up.
But now we have something much, much better.
Oh, worlds better. The modern gold standard is the Ga-68 DOTATATE PET scan. It's a mouthful to say, but the images it produces are just beautiful to look at.
What makes it so much better?
It uses the same basic principal binding to the somatostatin receptor, but the tracer is much more sensitive, and the PET scanner has incredibly high resolution. It's like switching from that fuzzy old TV directly to 4K Ultra HD. It's night and day.
So you can see tiny little metastases that you would have completely missed before.
Yes. We call it lighting up. The tumors just glow brightly on the scan against a dark background. It has completely changed the staging for a lot of patients. We find small volume disease we never knew was there, and that changes the whole treatment plan.
What about for the really tiny ones in the pancreas? Like a small insulinoma that's only a few millimeters. Can the PE scan see that?
Sometimes the PET scan can miss those if they are very small or if they don't have enough receptors. For that, we have another tool, endoscopic ultrasound, or EUS.
How does that work?
We put a flexible endoscope down the throat, into the stomach or duodenum, and there's a tiny ultrasound probe on the tip. We can put that probe right up against the wall of the stomach and look directly at the pancreas, which sits right behind it. It gives you millimetric precision. You can find a tiny tumor that no other scan could see.
Okay, so we found the tumor. Now how do we treat it? What's the logic?
The logic tree branches based on 2 main questions. Is it localized? And is it functioning?
Let's take the easy one. If it's localized, just one lump that hasn't spread, I assume we cut it out.
Surgery is the only curative option. For a small carcinoid tumor in the bowel, you resect that segment of bowel. For a benign insulinoma, a surgeon can often do a procedure called an enucleation.
Enucleation.
That's a very elegant surgery. It means you just carefully scoop the tumor out of the pancreas, like popping a pea out of a pod, and you spare all the healthy surrounding pancreatic tissue.
That's amazing. But what if you can't cut it all out? Or what if the patient is just miserable from the symptoms, the flushing, the diarrhea? We need to turn off that hormone factory.
This is where we use the off switch. Remember those somatostatin receptors that are all over the surface of the tumor?
The same ones we use for the fancy DOTATATE scan.
The very same ones. We can target them with drugs. The main ones are Octreotide and Lanreotide. These are synthetic, long-acting analogs of somatostatin. We give them as an injection, usually once a month.
Remember what they do?
They bind to the tumor and they send a powerful signal. Stop secreting!
It effectively puts the hormone factory on strike.
Exactly. It controls the flushing and stops the diarrhea. For patients with debilitating carcinoid syndrome, it is life-changing. It doesn't necessarily kill the tumor, but it controls the crime. And for gastrinomas, we also use high-dose proton pump inhibitors, or PPIs, to block the acid production directly.
But what if we do want to kill the tumor? What if it's metastatic and it's growing?
This is where we get into one of the coolest new fields in oncology. It's called theranostics, which is a combination of therapy and diagnostics. Remember the DOTATATE scan?
Yeah, the one that lights up the receptors like a Christmas tree.
Okay, so imagine taking that same molecule, the DOTATATE molecule that is so good at finding the receptor, but instead of attaching a tiny flashlight to it, the Gallium-68 imaging tracer, you attach a tiny bomb.
A microscopic targeted bomb.
Precisely. This is PRRT, which stands for peptide receptor radionuclide therapy. We inject a molecule, usually lutetium-177 dotatate, that hunts down the tumor cells, latches onto that somatostatin receptor, gets absorbed into the cell, and then releases high-energy beta radiation from inside the cancer cell.
So it radiates the tumor from the inside out.
It's targeted molecular warfare, and it's brilliant because it largely spares the healthy tissue, because most healthy tissue doesn't have those receptors. For patients with advanced progressive disease, it has been a game changer.
That is just sci-fi level medicine right there.
It's the future of oncology, and it's happening right now for patients with NETs. It's incredibly exciting.
Incredible. We have covered a massive amount of ground here. From the basic plumbing of the liver to the genetic code of MEN1 to radioactive missiles that hunt tumors. Let's try to bring it all back home for the listener.
Let's do the meta pattern recap, the big picture.
Okay, if you are listening and you want to lock this all in, here's your mental checklist. Step 1.
Step 1. Recognize the hormone syndrome. Don't just look at the mass on the CT scan. Listen to the patient. Are they flushing? Are they passing out from low sugar? Do they have these stubborn ulcers that won't heal? The story is in the hormones.
Okay. After you recognize the syndrome, what's step 2?
Identify the tumor. Map that specific symptom to the specific cell type. Flushing equals carcinoid. Low sugar equals insulinoma. Ulcers equal gastrinoma. The moving rash equals glucagonoma.
And step 3.
Check the context. Look for the associated clues. Is the liver involved? That's crucial for carcinoid syndrome. Is the patient's calcium level high? You have to be thinking about MEN1. Put the whole puzzle together.
That's a great framework. Let's do a quick rapid-fire recall to finish this off. I'll throw a key term at you. You tell me the immediate association. Ready?
Ready, let's do it.
WDHA syndrome.
VIPoma, watery diarrhea, hypokalemia, echlorhydria, pancreatic cholera,
Whippledy triad.
Insulinoma, the three-part proof of symptomatic hypoglycemia.
Right-sided heart murmurs and fibrosis.
Carcinoid syndrome. And remember, the lungs protect the left side of the heart.
Necrolytic migratory erythema.
Glucagonoma, the painful moving rash, usually with diabetes and weight loss.
The 3 Ps.
MEN1 syndrome, parathyroid, pancreas, and pituitary.
5-HIA.
The 24-hour urine test for carcinoid syndrome. And watch out for the bananas.
Fantastic. You know, when we started this, we talked about that patient, the one with the red face and the heart murmur, as this huge mystery. But now, after walking through the physiology, it makes perfect logical sense.
It really does. And that brings me to a final thought. In medicine, we usually think of tumors as physical obstacles. They're just lumps, things that block pipes or press on nerves. We call them space-occupying lesions.
Right, a physical mechanical problem.
But neuroendocrine tumors are a powerful reminder that the body is also a chemical soup. And these tumors are chemical factories. The most dangerous thing about them often isn't how big they are, but the microscopic messages they are screaming into the blood.
That's a really powerful image. You can have a tiny, almost invisible tumor that can hijack your entire body's function just by whispering the wrong chemical command into the bloodstream.
Exactly. They can hijack your heart, your gut, your skin, your brain, all from a hidden spot in your pancreas or your bowel. So as a clinician, or just as a curious person trying to understand the body, you aren't just looking for a lump. You're listening for a message.
If you can decode the chemical message, you can catch the killer.
That's the mission.
And that is a perfect place to end this. Thanks so much for taking us on this incredible deep dive.
It was my pleasure. Always fun.
And to you listening, stay curious. We'll catch you on the next deep dive.